afternoon, ladies and gentlemen. HIPECTreatment.com would like to welcome you to this HIPEC Facebook Live presentation entitled Defining the Role of Cytoreductive Surgery and Hyperthermic Intraperitoneal Chemotherapy in the Treatment of Peritoneal Cancer. Our presenter this afternoon is Dr. Richard Berri, Chief of Surgical Oncology and Director of the HIPEC program at Henry Ford Health St. John Hospital, Detroit, Michigan. Upon completing his surgical oncology fellowship at MD Anderson Cancer Center in 2011, Dr. Berri started the HIPEC program at Henry Ford Health St. John Hospital, where he's treated over 500 patients with cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. My name is Glenn Keeling. I will be your event moderator for the Q&A session following Dr. Berri's presentation. You will be able to message your question using the Zoom Q&A portion, and I will present your questions to Dr. Berri following this presentation. The HIPEC Facebook Live event and the Q&A session will be recorded and posted on HIPECTreatment.com for future view. At this time, it is my great pleasure to introduce our HIPEC Facebook Live presenter, Dr. Richard Berri.
Thank you, Glenn, and thank you to HIPECTreatment.com and the group for allowing me to present this work this afternoon. Today, I'm going to go through some of the definitions with regards to cytoreductive surgery and hyperthermic intraperitoneal chemotherapy and explain the role of that procedure and talk about eligibility and which patients might benefit most from this operation. Before I do that, as you can see, I'm going to go through some definitions about the basics of some terminology that you may or may not be familiar with. The first one is the peritoneum, and this is where the cancer that we're discussing can be found, and sometimes it can arise in the peritoneum or it can spread to the peritoneum from other organs. And so you can see in this schematic, the peritoneum is a thin membrane that lines the abdominal and pelvic cavities, and it really covers most abdominal viscera. And peritoneal carcinomatosis is when malignant tumors within the abdominal cavity attach themselves to this surface. There have been several different analogies to try to better understand this, and one of them that my colleagues and I sometimes use is we describe a room. And so if you can imagine a room that is a room with, let's say, a chair and a table. The chair and the table are the abdominal organs, and if the room had wallpaper, the peritoneum would be the wallpaper within that room. And so sometimes tumors spread to that peritoneum or the lining of the inside of the abdominal cavity, which would be similar to the wallpaper in a room. And to remove those tumors, we have to strip that whole area, or likened again, we have to remove the wallpaper of that section to remove the tumors. Moving forward, so cytoreductive surgery is really open or sometimes laparoscopic removal of tumor. And you can see in the schematic there, that's an open abdominal incision. I'll show some different pictures that look at other approaches, but cytoreductive surgery is removing the tumor from the abdominal cavity. The assessment of the tumor burden by the surgeon, once we enter the abdominal cavity, either via an open technique or a laparoscopic technique, allows us to determine if cytoreduction is possible. So as I mentioned, surgical removal of all visible disease is what cytoreductive surgery is. Sometimes it's called debulking surgery or other things. It may require the removal of any intra-abdominal organ, and sometimes that can include the small intestines or the large intestines, the rectum, the uterus, the ovary, the bladder, the stomach, the gallbladder, spleen, pancreas, liver, or really any intra-abdominal organ. These are only removed, of course, if there is disease attached to them that cannot be removed otherwise. And again, the goal of cytoreductive surgery is to remove all visible disease. And I can't emphasize that enough. That is a key point of the procedure. Now, sometimes we can even remove all the disease and do cytoreductive surgery without HIPEC in select cases if needed. But most often, if we're able to remove all the disease in cytoreductive surgery. We then proceed to the HIPEC part of the operation, and I'll explain that in a few minutes. Sometimes this can be done with an open incision, as you can see here, or even laparoscopic. At the end of the part of the operation where we remove all the disease, we then assign a score that's called a completeness of cytoreduction score. And as you can see here, it's scored either 0, 1, 2, or 3. This score tells us if we've removed all the disease. And you can see a CCR 0, which a surgeon might say or share with you or refer to, means that there is no longer visible evidence of tumor once the cytoreduction part has been completed. And that really is the goal. If we cannot do that, a CCR1, which means residual tumor less than 2.5 millimeters, is still an acceptable outcome in some cases. If you see at the bottom of the screen, CCR2 or 3 means there's more disease than 2.5 millimeters left. And in those cases, we do not then proceed to the HIPEC part of the operation. And so really our goal is to achieve a CCR 0 in all cases, or 1, to allow us to proceed with the rest of the operation. So this heated intraperitoneal chemotherapy, or HIPEC, is the next part of the operation after cytoreduction is performed. And so essentially it's infusion of a liquid heated chemotherapy into the abdominal cavity using a perfusion circuit. And this is done, again, after completely removing all the tumor in the operating room at the time of the operation. The duration of the infusion can last anywhere from 60 to 120 minutes, on average approximately 90 minutes. And again, this is in the operating room during the operation after all of the disease was removed. The fluid and chemotherapy are heated anywhere from 41.5 to 43 degrees Celsius. And different chemotherapies are used with regards to the primary tumor that is being treated. Some of the most common chemotherapies that we use are things called, as you see there on the slide, mitomycin C, cisplatin, or oxaliplatin. For appendiceal tumors, which are a common indication for this procedure, and for colorectal cancer, we most often use mitomycin C. These are some schematics and pictures of how the heated intraperitoneal chemotherapy looks. And you can see in this schematic, this is the infusion of the heated chemotherapy through this circuit that continually cycles the chemotherapy that is heated by the machine through the abdominal cavity, then back to the reservoir to continue to cycle this fluid through. The picture on the left is an incision, an open abdominal incision with an inflow cannula and an outflow cannula that is infusing the heated chemotherapy. And again, this can last anywhere from 60 to 120 minutes. The picture on the bottom is a operation done laparoscopically with only 3 small incisions. You can see there the inflow cannula and the outflow cannula during this laparoscopic perfusion that can be used in some cases. This will last then for the duration of time, as I mentioned. At the end of the heated intraperitoneal chemotherapy part of the operation, we then reopen these incisions and then continue the operation, do any form of reconstruction of the GI tract that is needed, and then end the operation by reclosing the incision. So peritoneal cancer is really any cancer that is spread to the peritoneum, or in some cases, there are cancers that originate in the peritoneum. Again, this peritoneum is the lining that I talked about a few slides earlier that lines the intra-abdominal cavity. And there are primary peritoneal cancers. One of them is called mesothelioma. Another is called primary peritoneal cancer. Mesothelioma of the peritoneal cavity is quite rare in the United States. We believe there's only 3 to 350 cases a year. But the treatment of that cancer ideally can be treated with cytoreductive surgery and HIPEC if a patient is a candidate for that, because there are few other treatment options for those patients. Primary peritoneal cancer also is a type of peritoneal cancer that originates in the abdominal cavity, in the peritoneum. More commonly are, as you see on the slide, metastatic peritoneal cancers. And this is, as you see on the slide, the majority of these are either colon cancers, appendix cancers, ovarian cancers, or other types of GI cancers that have started in those organs, but then escape from those organs and spread into the peritoneum. And so once that happens, we then, in some cases, consider these patients to be candidates for cytoreduction and heated intraperitoneal chemotherapy. So those are some introductory definitions. As we move along in the discussion, I'm going to mention briefly the history of the operation, some of the indications, the criteria for selection. I'm going to talk about something called the Peritoneal Cancer Index, which is extremely important, and talk further about how to evaluate patients for this operation, and then share some data and comments about experience of the team. And so historically, this is Dr. Sugarbaker. In 1982, he began his series of advanced peritonectomies for appendiceal cancer. And you can see, even before that, in the early 80s, there were thoughts of tumor reduction, which is essentially cytoreductive surgery, in female patients with ovarian cancer. And so since that time, since 1980 and since 1982, since Dr. Sugarbaker started that work, there has been extensive work and throughout this country and throughout the world, there are now several hospitals and several programs throughout the country that focus on peritoneal cancer and using these types of procedures that Dr. Sugarbaker first described in 1982 to treat patients. And so just a little bit of a historical perspective. And so what are the indications for evaluation for this operation? Well, you can see here, appendiceal cancer is one of the more common reasons for evaluation. Colorectal cancer, peritoneal mesothelioma, as I mentioned, primary peritoneal cancer, and ovarian cancer. And so those top 5 cancers are our most common and most studied indications for HIPEC evaluation. I will see patients in other settings, and people will ask if patients with other cancers are appropriate candidates for this operation. And you can see here I've listed gastric cancer, small intestine cancer, sarcomas, pancreas cancer. There is some work in each of these areas on whether or not HIPEC is appropriate, but we take these more on a case-to-case basis and do individual evaluation for these patients. But the first top 5 disease sites that I've listed here are the more common indications. So after diagnosis, who's eligible for CRS and HIPEC, and how do we select patients? I really believe that any patient with peritoneal carcinomatosis from a GI or GYN malignancy who has an acceptable performance status, which means that the patient has a good functional status in doing their daily activities, and who has no evidence of disease outside of their abdominal cavity, and that's what without extraperitoneal disease means, and is of the appropriate age with reasonable comorbidities. And that comorbidities refers to any other diseases that the person might have, heart disease, lung disease, renal disease. If patients have limited amounts of those conditions that require extensive treatment and meet these criteria, we should at least be able to have a discussion with patients about what the options might be and if they're eligible for this operation. And so as you can see, they should at least be evaluated by a multidisciplinary team that includes a surgical oncologist who has experience in this discipline to allow them at least the opportunity for this procedure. So what should that evaluation include? A multidisciplinary team is key for any person with any type of malignancy or cancer, and especially in this disease site. And so that multidisciplinary team can include a surgeon, a medical oncologist, a radiation oncologist, radiologists, pathologists, other types of surgeons, all coming together to study a case and determine if this procedure, CRS and HIPEC, is an option for them. It includes an exhaustive review of all the records, pathology, laboratory, imaging, operative notes, office notes, and then, if needed, and distance is far, a potential first virtual interview or evaluation, followed by then an in-person evaluation. Routinely, because some of these cancers are quite rare, we always advocate and encourage repeat or second opinion evaluations of the pathology that someone may have been diagnosed with, especially with tumors of the appendix and other tumors that are rare, like mesothelioma. We review all pathology to determine truly if that is the underlying pathology, as this can dramatically change the treatment plan when evaluations of pathology are reviewed. We sometimes do repeat imaging in the evaluation, repeating a CT scan, an MRI, a PET scan. Other tests are used. Something called diagnostic laparoscopy in the evaluation can be used. And this is a procedure where we go to the operating room and we look into the abdominal cavity to determine the extent of the disease. And this can sometimes give us more information than the imaging studies that are performed. And then overall, an evaluation of the entire person and their situation to determine if this is an appropriate procedure for them. With regards to imaging, as I mentioned, and if people undergo imaging, sometimes the role of laparoscopy, looking into the abdominal cavity, is extremely important, because in some cases, even if patients have imaging studies, PET scans, MRIs, and this is an example of a PET scan, an MRI, and a CAT scan, not showing any evidence of disease, but when we look into the abdominal cavity laparoscopically, we can sometimes see disease, as you can see here, that is not seen on these imaging studies. So it's very important to have this comprehensive evaluation. And so then what determines if someone after this evaluation is a HIPEC patient or a candidate for this, and how best to select? Well, it's really the biology of the disease and the primary site. And by this, we mean under the microscope, how does the disease look and what grade is it? Low-grade tumors in general offer patients more opportunities for this operation. High-grade tumors sometimes we're not able to operate on those patients, or sometimes those patients will need more extensive IV chemotherapy. But really, it's looking at the biology of the disease and the site of the tumor. Appendiceal tumors, some colorectal tumors can be options for patients, but in some cases, other disease sites and different grades of tumor, we don't give patients the opportunity for this operation. The function of the person, as I mentioned before, which is called their performance status, and then the amount of disease and the location of the disease and the surgeon's ability to remove the disease is another extremely important factor when considering if someone is a candidate for this. And so we describe the volume of disease by something called the PCI, which is the Peritoneal Cancer or Carcinomatosis Index, and I'll share the details of that with you in a moment. And then whether or not there's disease outside of the abdomen in other organs. So looking at these three factors, the biology of the disease, the function of the person, and then the amount of disease and location and our ability to remove it all, really are the three factors that determine if someone is a candidate for this operation. And this is the Peritoneal Cancer Index that I mentioned, and it's briefly a scoring system that goes from 0 to 39, 0 meaning no tumor, 39 meaning tumor extensively in all 13 areas. And when we operate on someone or do laparoscopy even, we calculate this number and then determine if surgery is appropriate. And I will even share this number with patients before the operation if I've done laparoscopy. And again, the lower the number, the more likely surgery is to be successful in removing all the disease and being able to administer the heated chemotherapy at the time of the operation. So once the evaluation is complete, what are the options? Sometimes we offer further testing or further evaluation based on a multidisciplinary team. Sometimes after all of these criteria have been taken into account, surgery is an option, cytoreductive surgery with HIPEC. Sometimes systemic chemotherapy or IV chemotherapy is needed as a bridge to potentially get to surgical treatment. And then in some cases, we may say this person is just not a candidate for surgery. But I think it's important, even if someone is not a candidate for surgery, to at least have the evaluation to determine if it was an option for them or not. With regards to data, there is data that shows us that CRS and HIPEC can work for patients, and there are randomized trials that were published. There was one randomized trial published about 20 years ago that suggested that heated chemotherapy and cytoreductive surgery for colorectal cancer improved survival. There are further studies that show that as well, and there are consensus statements that surgeons have collaborated with around the United States and have now published showing standard approaches to all of these cancers, and a lot of it is based on outcome data, showing very durable survival in some cases when we can operate on patients who have the appropriate criteria. And again, most importantly are the grade of the tumor. And so a low-grade tumor with a lower volume or lower amount of disease in a patient who has a good functional status. If we can offer surgery to those patients, then in many cases, the survival outcome is markedly improved for different diseases. At my center here, we published our own data of our first 10 years of experience. And again, we showed and highlighted our 5-year survival for many different patients with different diseases and showed that in combination with systemic chemotherapy, patients who undergo cytoreductive surgery and heated intraperitoneal chemotherapy can have very favorable long-term survival outcomes. So finally, the goal of HIPEC really is to control the peritoneal disease and decrease the time to recurrence of that disease and decrease overall the burden of that disease. It can be looked at in times as an alternative to staying on chemo for a long period of time. And it also can be looked at as improving a patient's quality of life in some respects if we're removing tumor that was causing symptoms. And ultimately, our goal is to benefit the patient and improve their survival. So finally, in conclusion, patients with peritoneal carcinomatosis who have complete cytoreduction followed by HIPEC appear to have a significantly improved survival, as opposed to patients who got chemotherapy or other treatments only. And this is especially true for patients with appendiceal tumors, mesothelioma, and in some cases, colorectal cancer. Appropriate selection of the person for this procedure is essential, and evaluation by an experienced multidisciplinary team, including a trained surgical oncologist, is also very important. Further randomized trials, research, and more widespread knowledge of and awareness and utilization of this technique is necessary to continue to move forward. So with a plan comes hope, and ultimately, I think all patients, again, who have a diagnosis of peritoneal cancer deserve an opportunity to visit with a multidisciplinary team and discuss the options for treatment. So this is my contact information, and I'm happy to answer any questions. Thank you, Glenn, and thank you to the HipecTreatment.com group for allowing me to discuss this evening.
Dr. Berri, we do have some questions coming in. You may have answered this one already. How do you select patients for this procedure, and what are the criteria?
Yeah, that's a good question, Glenn. I mentioned in the discussion the three main criteria are the functional status of the person, a person's ability to handle the operation, the biology of the tumor, where it originated, and the grade of the tumor, low grade being more favorable, higher grade being less favorable, and then the amount of tumor in the abdominal cavity, judged sometimes by that PCI or the peritoneal cancer index, and our predicted ability to remove all of the tumor.
Okay, another question coming in. You mentioned primary peritoneal cancer is rare. How common is metastatic peritoneal cancer among patients with pre-existing cancers? Does it differ by organ?
The different disease sites, for example, gastric cancer or colorectal cancer or ovarian cancer, appendiceal cancer, all have varying rates of spreading to the peritoneum. Interestingly, gastric cancer, cancer of the stomach, has one of the higher rates of spreading to the peritoneum, and thus many patients with that type of cancer will have their abdominal cavity evaluated by laparoscopy to determine if they have this, because as I mentioned, sometimes imaging studies, CT scans, MRIs, PET scans, do not visualize this disease. In colorectal cancer, which is one of the more common cancers in the United States, with approximately 150,000 new cases per year, there are at least each year 15 to 20,000 cases of patients with peritoneal cancer from their colon cancer. So that is patients with colon cancer who have a primary cancer of part of their colon that is then spread to the peritoneal cavity.
Another question coming in. Is there a PCI threshold beyond which patients will likely need repeat HIPEC procedures and or be denied surgery?
Thank you for that question. This depends on the disease site mostly. And so with tumors of the appendix, especially low-grade mucinous tumors of the appendix, we do not use PCI as a criteria for not offering the operation. However, the PCI can predict the chance of recurrence. And so as you can imagine, even with low-grade tumors of the appendix, the higher the PCI, the more likely there is for recurrence. With other tumors, though, especially with colorectal cancer, there is data to suggest that when the PCI exceeds a certain number, cytoreductive surgery and heated intraperitoneal chemotherapy may not be that beneficial. And for the majority of time in my practice, I use the number of 19 to 20 as a cutoff. And so if patients came to me with a value of 19 to 20, I may not offer them the operation upfront and may offer further systemic chemotherapy. There is other data that is published that suggests that patients in the 12 to 15 PCI range may benefit from cytoreduction. But in general, the lower the PCI, the better. And in patients with colorectal cancer in particular, we do look at a number, in the 15 to 20 range, where in some cases we will not offer them surgery if the number is above that range.
Okay, another question coming in. What are some of the disqualifying comorbidities for the HIPEC procedure?
There are many comorbidities that would not allow us to do the operation. Patients with significant cardiac or heart disease, and they would have to be evaluated by a cardiologist and the heart function studied. Patients with significant pulmonary or lung disease who have a history of difficulty breathing or who are dependent on oxygen would again have to be assessed, and they may not be candidates for the operation. Patients with impaired kidney function, because it's important during and after the operation to have adequate kidney function. In some cases, patients who are already on dialysis or other means of kidney support may not be able to tolerate this operation. So we look carefully at all of the comorbidities and really at the patient. And so it's not that we can generalize completely that there are cutoffs for all of these, but it's really looking at the patient and all these comorbidities, if they have them, to determine if we think it's safe for them to have the operations.
Another question coming in. Are there ever special circumstances in which a patient with a CCR higher than 1 would still be recommended for HIPEC?
So in the data that I published and in others have published, in some cases of mesothelioma, which is a type of peritoneal cancer that can be very extensive at the time of operation, those patients in some of our literature benefit from cytoreduction and HIPEC even if the CCR is above 1. There are other cases where, unfortunately, some patients have fluid in the abdomen called ascites that does not stop accumulating after chemotherapy. And in these cases, we may offer those patients HIPEC to help stop the ascites from reaccumulating, even if we're not able to achieve a CCR of 0 to 1.
Okay. Next question. Can you speak to your experience as a surgeon with patient outcomes for this procedure?
Yeah, I think all would agree that this operation, like many major oncological operations, has been studied, and there's been a defined learning curve that has been studied, and any center with more experience is sometimes able to offer patients a safer and higher quality outcome. And so anyone who is a potential candidate for this operation, I would encourage always to seek opinions from different surgeons and for those who might have as much experience as they can have in treating this disease, because we've seen as the experience of any operating team improves, the outcomes with regards to quality and safety of the operation also improve.
Another question. How long is the surgery and how long is the hospitalization?
On average, in our data, and similar to others who have published data throughout the country, the average length of our operation over those 353 cases was 9 hours. Now that's average, so some are less, some are more. I tell patients on average about 8 to 9 hours. It can be as short as 3 or 4 hours, or even as long as 15 hours or more, depending on the disease site. The length of stay on average in our series is 8 days, similar to other reported lengths of stay in the literature. Again, depending on the extent of the operation, you can imagine the longer the operation and the higher the PCI, sometimes the longer the stay in the hospital. The shorter the operation and the lower amount of disease removed, sometimes the length of stay can be as short as 3 to 5 days. When we do the operation laparoscopically, and if there is low volume disease, our average length of stay for those patients is 2 to 3 days. But it really depends on the operation and the amount of tumor removed and the functional status of the person.
Another question. Can a patient have more than one HIPEC procedure?
That's a good question. Yes, the answer is yes. With appendiceal tumors, especially low-grade mucinous tumors of the appendix, chemotherapy through the vein is not a very effective treatment. And those patients who have surgery with a high PCI can have a higher chance of recurrence. And so over time, they can have repeat evaluations. And if we discover there is recurrence of the mucinous disease, we then, in many cases, if their performance status or functional status allows, we offer them repeat operation. And so it's not unusual for these patients to have another operation. With other disease sites is not as common, but there are examples, and I have, even in my series, patients who've had more than one heated chemotherapy procedure. In general, I and others may not repeat the operation within a 12-month period of the first operation. So if we do an operation that includes CRS and HIPEC, and we're planning to do another one, or if there is disease recurrence, we will not do it within a 12-month period of the first one. But certainly, reevaluation and repeat operation is indicated for some disease sites, and there are patients in our series and others who have had multiple procedures over a several-year period of time.
Another question here. Do you take patients from abroad?
So we have, starting in 2011, we have a large volume of patients that come from out of the region and some out of the country. We're fortunate enough here, and I know other centers as well have on-campus housing where we allow patients before the operation and their family to stay in those facilities. And then during the operation, the patient's family, of course, can stay in those facilities. And we ever then offer them, once they're discharged from the hospital, we allow them to stay in those also if they've come from far away, just to have post-operative evaluation until we're confident they can return to their home. And so we try to make it, our program and others throughout the country, try to make it as easy as we can for patients who may be traveling from far away to have the opportunity to have this procedure in a center that has experience.
Okay, Dr. Berri, in closing, what ultimately sets your program apart from other HIPEC treatment programs?
I think myself and all of the HIPEC surgeons around the country all want to do our best to help our patients and offer them the best outcomes. We're very proud of our long-standing history since 2011 of being able to offer this operation to many patients throughout this region and beyond. And we wanted to document that. And so we published a paper recently showing the long-term survival results, which were very favorable for certain disease sites. And so we have, from the beginning of the program, had a stable team that includes the same members on the team since 2011, and standardization of care really allows for a safe operation and a high quality outcome. And so I think that's one of the key benefits of our program.
Dr. Berri, I want to thank you for the great presentation, and I'm sure all the people that attended your talk really appreciate it. And again, thank you very much. Have a great evening.
Thank you, Glenn. Thank you, everyone. Good night.